Good morning, everyone. Myself, Dr. Praveen Vasantan, Department of Sports Physiotherapy, School of Physiotherapy, SBV Chennai. It gives me an immense pleasure to welcome you all to today's case-based learning session organized by Sports Physiotherapy Department, School of Physiotherapy, SBV Chennai. Case-based learning, as we know, it is an interactive and student-centric approach that bridges the gap between the theory and the clinical practice. Through real patient scenario, it encourages clinical thinking, clinical reasoning, and clinical practice. So first foremost, I would like to welcome our principal, Dr. Muthukumaran, to the session. And also I extend my welcome to all the faculty members and my dear students. Let's make this session more interactive and critical thinking so that the purpose of the session will be solved. Without any further delay, I'd like to hand over this session to Valliyappan, postgraduate sports physiotherapy department, to take away the case-based learning session.
Good afternoon, everyone. Valliyappan, PG in sports physiotherapist. It's a case-based learning session. The case of ACL reconstruction. The patient name is Rajadurai and age is 26. The chief complaints are the patient complaints of pain over the left knee for 2 days and difficulty in bending the knee and unable to weight bear over left leg. The present history is the patient was apparently normal 6 months back, after which patient gives an alleged history of trauma, slip and fall while playing cricket and had a sustained injury to left knee. Patient developed a pain with was sudden in onset and gradually progressive in nature, aggravating on movements and relieving on rest. Pain didn't subside, so the patient came to SSMCRI. Here, the patient diagnosed with the ACL complete tear in MRI findings and operated on 7th. Left knee ACL reconstruction surgery. Surgical note. The 3 × 2 centimeter linear incision made on medial aspect of the distal portion of right leg and the peroneus longus graft was harvested. And proximally at the left knee through anterior approach, portal entry was made and arthroscopy was introduced. Through synovectomy was done. And there is no abnormalities in lateral and medial meniscus. After this, the ACL was visualized and complete tear was confirmed. Tibial tunnel of 8 mm and femoral tunnel of 7.5 mm was created and harvested, was put in the place with the help of 5 ethics. Bioabsorbable endo button was locked in place using inference screw. The movement and stability of the knee was confirmed and the post-Lachman test was negative. Through wound wash was given, the patient was stable, so they have shifted them to the post-op ward. It's a key scenario. Pain assessment. The side is over the left side and side is over the knee, around the tibial and femoral tunnels, and lateral leg to the peroneus longus graft harvest site. The severity is 6/10 according to NPRS. The irritability is moderate and the nature of the pain is dull aching pain over the knee joint. And the aggravating factor is during left knee movements and the relieving factor is left knee joint in at rest. On observations, build is mesomorphic, posture is normal, patient is mobilizing with a walker, gait is non-weight bearing gait with walker support, and swelling is present around the joint. Muscle wasting, there's no muscle wasting, and attitude of the limb is hip in neutral, and knee is slightly flexed 15 to 20 degree, and the ankle is in plantar flex. On palpation, temperature, local rise of temperature, and tenderness is present over the anterior aspect of the knee joint near the incision site. There is no spasm. The edema is non-pitting edema. On examination, we have examined the range of motion. There is a 5-degree lag. Knee flexion is 5 to 40 degree, and the knee extension is 40 to 5 degree. And muscle power using MMT, the knee flexor is 2 plus by 5, and the knee extensor is against the gravity, that is 3 out of 5. In surgical notes, we have discussed about 5E ethymon. It refers to it is a non-absorbable braided polyester suture. It is commonly used in orthopedics and also commonly used in soft tissue surgeries, which is a long-term tensile strength. And common surgical users using this 5 ethymon is this tendon repair like Achilles tendon and patellar and rotator cuff tendon. In ligament reconstruction, for example, ACL, here we have done the ACL, and capsular or joint stabilization procedures. And other than is bioabsorbable endo button, It is a temporary implant used to secure soft tissue grafts like hamstring or patella tendon graft to the bone tunnels, most often on the femoral side during ACL reconstruction. This is the mechanism of injury. There are two types of mechanism of injury. One is contact and another one is non-contact. In contact, there is a direct blow or collision. In non-contact, there is a sudden deceleration or during pivot or cutting with knee slightly flexed or during landing from a jump with knee slightly flexed, twisting on a fixed foot. The contact during contact sports, the contact mechanism of injury happens like rugby and football tacklings. In non-contact mechanism of injury, it happens commonly in basketball, football, and cricket. In this case, the athlete is presented with landing from a jump with knee slightly flexed during playing cricket. And the pathophysiology of this condition, the ACL is stressed beyond its tensile strength by fiber disruption, ligamentous elongation, hemorrhage and synovial reaction, joint instability. In fiber disruption, there will be a partial or complete tearing of collagen fibers. In ligamentous elongation, there will be a microscopic stretching before the complete rupture. And in hemorrhagic and synovial reaction, there is an immediate intra-articular bleeding. It is called as hemorrhagosis. And joint instability, there will be a loss of primary control. That is, the anterior translation of the tibia control will be lost, and the limitation of rotational force will be lost. At immediate effect, during and right after the injury, there will be a sharp pain or popping sound over the movement, and there will be a knee instability, like giving away episodes, and rapid swelling with 1 to 2 hours, and loss of range of motion, and bending or straightening the like flexion and extension, and there will be a tenderness along the joint line, and there will be inability to continue activity or bear full weight bearing. After that, from day 2 weeks, if it is untreated, from day 2 weeks, it will be persistent swelling and stiffness in the knee, pain and weakness, especially during walking or stair climbing, and there will be a muscle inhibition. The quadriceps muscle will often go to weakness, and there will be reduced proprioception. The balance will be lost, and fear of avoidance of movement due to instability. In long-term effect, if it is untreated or improperly managed, there will be a chronic knee instability, like giving away episodes. There will be a episodes, and secondary to that, without ACL, other ligaments will get stressed, like meniscal tears and articular cartilage damage. Altered to biomechanics, the gait will be get abnormal, and the movement pattern is also getting abnormal. There will be increased stress on other ligaments and muscles also. And coming to muscle atrophy, mainly quadriceps and the hamstring get weaker, and early onset of osteoarthritis. There will be reduced performance sports and daily functional tasking. Psychologically, the athlete is fear of re-injury and reduced confidence and anxiety during return to sports. After surgery, what are the pathophysiologies? Surgical goal is to restore the knee stability by replacing the torn ACL with a graft. It mimics the function. There are types of graft: autograft and allograft. In we are commonly used only autograft. Autograft, we have hamstring tendon graft, bone patella tendon graft, quadriceps tendon graft, peroneus longus graft. In this case, they have used the peroneus longus graft. And then coming to biological healing phase, when the graft is placed, it undergoes a ligamentization process. That is ligament-like tissue, from tendon tissue to ligament-like tissue. Phase 1, early healing phase, from 0 to 6 weeks. The graft acts as a mechanical scaffold. The necrosis of the central cells, the graft necrosis found in the central cells of the graft, an inflammatory response and new vascular ingrowth from the bone tunnels. Phase 2, there is a proliferation from 6 to 12 weeks. Fibroblast infiltration and collagen remodeling begin. The graft becomes biologically active but mechanically weaker. From till this stage, the orthopedic work is done. From the mechanically weaker, from here, our physiotherapy role is getting stronger. That is, rehabilitation must be controlled. In phase 3, remodeling and maturation from 3 to 12 months. Collagen fibers align along stress lines, increased cross-linking and stiffness, gradual restoring of strength and proprioception function. It is a neo ligament, forms with structural and functional similarity to native ACL. Then biomechanics of the joint. The normal biomechanics of the knee joint before injury. The ACL is a key stabilizer of the knee joint. It prevents the anterior translation of the tibia on the femur. It resists translation force, especially internal rotation. During normal movements, ACL guides coupled motion like knee flexion. During knee flexion, the femur rolls and glides on the tibia. It maintains joint congruency, load distribution, and rotational stability. It helps to maintain knee stability during dynamic movements like jumping, landing. Changes after ACL injury. Once the ACL is torn, the stability triangle is disrupted. That is bone, muscle, and ligament. This triangle is disrupted. There is a loss of static stability. The tibia moves excessively anteriorly relative to femur and increased tibial rotation. That gives a poor rotational control and increased joint shear and compressive force, especially on the medial meniscal and cartilage. This is the reason for the secondary damage over the medial meniscal and cartilage. And this is static. When coming to dynamic, walking and running, there is an increased anterior tibial translation and internal rotation. While landing, there is an inability to absorb shock properly. So there is a valgus collapse. And pivoting or cutting phase, increasing the knee valgus plus internal rotation. That gives an instability episodes. And biomechanical changes after ACL reconstruction. Already we have spoken about the types of graft. In that, here is the tensile strength. Here we have used the peroneus longus graft, that is about 2,500 to 3,000 newtons. The native ACL is 2,160 newtons. So it provides a good anterior stability and rotational control. The peroneus graft, the graft placement and orientation. The correct placement of the tunnel positioning determines the graft function and tension pattern. The first is femoral tunnel, and it is positioned at anatomic ACL footprint at the same place where the native ACL is inserted. The key biomechanics is it controls rotational stability. And in tibial tunnel, it is positioned anterior to the PCL, which controls the anterior posterior translation. Coming to problem identification, what are the functional limitations? The athlete difficulty in walking, stair climbing, running, jumping, and difficulty in balance. In impairments, there is a reduced range of motion, reduced muscle power, that is muscle weakness, and reduced proprioception. And in activity restriction, there will be difficulty in performing daily day activities like bending, lifting, kneeling, and inability to perform in sports training, difficulty in returning to occupational tasks. When coming to participation restriction, inability to return to competitive sports or recreational games, and reduced confidence or fear of re-injury, limited participation in social or outdoor activities, and occupational limitations. Clinical reasoning pathway. In this, for assessment, we have used the NPRS, and range of motion, we have used the goniometer, and muscle power, we have used MMP. The problem is pain, reduced range of motion, reduced muscle power, and our goal is to reduce the pain, to improve range of motion, and to improve the muscle power, also the balance. In intervention plan is according to the rehabilitation protocol, and the expected outcome is NPRS is 4/10, and in knee flexion and extension we have expected around 0 to 60 degree, and knee extension is 60 to 0 degree. Treatment goal setting, short-term goal, protect the graft, reduce swelling and minimize pain, restore full extension, gradually improve flexion, regain full active extension, and also we should educate the patient that the knee should be kept straight and elevated when sitting or laying down. Do not rest with the towel when placed under the knee, because it will be in the knee extension lag. And do not actively kick your knee out straight. Support your surgical side when performing transfers. We have to give the patient education. And coming to long-term goal, from 6 weeks to 9+ months, we should give the BI training, initiate proprioceptive training, and safely progress to strengthening, and initiate single leg plyometrics, and safely initiate sport-specific training program, symmetrical performance with sport-specific drills, and safely progress to full sports. These are the intervention plans. Here we have discussed only phase 1 and phase 2. Phase 1 is 0 to 2 weeks. That is swelling management from we can give ice compression, elevation, as well as ankle pumps. In range of motion, there is a seated assisted knee flexion and extension, heel slides with towels, and low intensity, long duration extension stretches like prone hang, heel prop. I have shown in this image is heel prop and standing gastrocnemius and soleus stretch, supine active hamstring stretch and supine passive hamstring stretch. And coming to strengthening, calf raises, quadricep sets, straight leg raise, hip abduction, that is side leg raise, and multi-angle isometric. In this image, I have shown the multi-angle isometric, that is 90 degree of knee extension in isometric. And weight bearing is as tolerated. Initially, brace locked with crutches as per the doctor recommendation. And in phase 2, up to 3 to 5 weeks, range of motion, we can train stationary bicycle, and we can do gentle stretches, that is prone quad stretch, standing quad stretch, kneeling hip flexor stretch. I have shown in the image the kneeling hip flexor stretch. And in strengthening, we can use standing and prone hamstring curls, step ups and step ups with marching, wall squats, wall slides, mini squats from 0 to 60 degree. Gym equipments, we can give leg press, seated hamstring curl, and strengthening lumbopelvic is also very important. That is bridging and unilateral bridging and clamshell, bridges on the physio ball, hip hike. Balance is also very important. Single leg standing balance, lateral step overs, joint positioning retraining. These are the evidences. An outcome measure. The day 1 is on 8th. We have taken this outcome. That is pain is 6/10. Before on 10th, this is the outcome. NPRS is reduced to 2. And in range of motion, flexion is from 5 to 40 degree. We have improved 30 degree of flexion. And in extension, also we have improved. But extension, we are concentrating over extension, the 5 degree lag. In muscle power, we have increased the knee flexor up to 3/5. Summary, this case-based learning focuses on 26 years old male who underwent a ACL reconstruction surgery after a sports injury. It highlights clinical reasoning, pathophysiology, biomechanics, and phase-wise rehabilitation for pain reduction, range of motion improvements, and muscle strengthening. The case emphasizes the importance of evidence-based physiotherapy and gradual functional recovery through structured rehabilitation. These are the references. Thank you.
Thank you, Mr. Valliyappan. Am I audible?
Yes, sir.
Yeah, it was really a good presentation and it's a good initiative.
Thank
I
you.
should congratulate for your clear presentation. And coming to your case,
Sir.
and the question is, what was your immediate goals? Immediate goal pertaining to this patient, what you are addressing right now, because it's a POD1, isn't it?
Yes, sir.
Yeah, what was your immediate goals to achieve within a week of time pertaining to your patient?
Sir, actually, we should concentrate on the extension lag, sir, because patient is having 5 degree extension lag.
So how you are going to prevent it? How you are going to prevent the progression of the extension lag?
So by using quad sets and terminal knee extension.
Okay.
So by stretching the hamstring.
What is the primary advice? Yeah, stretching the hamstring is another thing. Where the graft has been taken for this patient?
Peroneus longus graft.
Peroneus longus. So considering that, but still, when you are addressing the extension lag, how you are going to prevent it? Of course, doing a quadricep sets or like knee extension, active knee extension does play the role. But how you are going to primarily position the leg in order to prevent the extension lag?
Yes, sir.
I think you did talk about that as well.
Yes,
Yeah.
sir. By keeping the leg in the extension position with the elevated leg, that the knee should be in neutral.
Yeah, elevated leg. Yeah. So the primary thing to insist not to keep your pillow or your rolled towel under the knee during the acute phase. I think you did emphasize that, right?
Yes, sir.
Yeah, good. And other thing is, what are the precautions you have taken for this patient when you are giving the intervention, during the intervention? What are the precautions you did maintain pertaining to this case?
Avoiding the towel over the under the knees because it will contract the
Yeah, that's the
hamstring.
advice you got given.
Yes, sir.
That's the advice you got given to prevent the extension lag. But when you are giving the therapy to the patient, okay, how did the patient cope with your treatment? Because what was the exercise parameters? You did talk about the exercises, heel slides with the towel, prone hangs, or heel drops, all those stretches, and then exercises. What
Yes,
was the exercise parameters the patient had tolerated? How
sir.
many reps or sets was they able to cope up with?
Sir, you're asking about the parameters.
Yeah,
Uh,
yeah, parameters. How many repetition? What was the
10
rest
reps and
interval?
2 sets, sir.
How did you progress
According
the
to the
exercise?
protocol, we
Yeah.
have given 10 reps and 2 sets. Initially, we have given 10
Was the
reps.
patient able to tolerate that parameter?
Sir?
Was the patient able to tolerate those parameters?
Yes, sir. Yes, sir. He's a young patient, so he can able to tolerate.
Okay. What was the mechanism of injury for this guy?
Jump and fall, sir.
Jump and fall. I mean, during a sporting activity or
During playing cricket, sir.
playing cricket?
Yes, sir.
Okay. Have you sustained any other injury before?
No, sir.
Okay, fine. Fine. I just opened the forum to the my colleagues and then my other PG students. If you have any other questions, you can ask. Yeah, Dr. Praveen, you can.
Yes, sir. Yeah. So my question is, do you have any patient education, formal patient education about the injury or any kind of patient education you are given to this particular patient?
Yes, sir. I have given patient education, sir.
Because see, actually, he is also seems like a not a regular athlete. He is a recreational player, maybe. So the proper education about how the ACL works or what is the importance of protecting the graft is an essential information. So, if possible, you could have. I didn't see any intervention for that particular in your treatment protocol. So, if it's so, just add an importance of those patient education also into your intervention.
Okay, sir. Sure, sir.
And then did you introduce hamstring flexion, mean knee flexion you started for the patient?
Yes, sir. What, sir?
Hamstring activity has been initiated.
Yes, sir.
That's the hamstring activity initiated.
Yes, sir. We have given the heel slides.
So you are just heel slides.
Yes, sir.
Okay, that is what, whenever you are mentioning your treatment protocol, you have to give the treatment protocol with all the parameters, like how much the intensity or what type of exercise you choose. At least you should use FIT principle to document your treatment protocol, the frequency and the intensity and the type and time and repetition, how many times you have did like that, you have to give your intervention protocol.
Sure.
Whatever the protocol you have submitted, right, seems like the guidelines, but try to add the exact treatment protocol what you given to the patient to the presentation.
Okay.
Whenever you are presenting your treatment protocol, it should be at least in FIT principle.
Sure.
Frequency, intensity, type, and time bounded, like that.
Okay, sir.
So that's what my suggestion from my side.
Thank you, sir.
Thank you, sir. Thank you for the opportunity.
Yeah, thank you, Dr. Praveen. And one more thing, Valliyappan, So consider using the questionnaire, because I don't think you have used any questionnaire to the patient, because he is a young champ.
Yes,
Still,
sir.
he is going to be working again and he has to play.
Okay.
Consider using a questionnaire pertaining to ACL rehabilitation or surgery, like a FOOS questionnaire or something else. Find a
Okay.
suitable questionnaire and
Okay.
then use that as well. Okay.
Okay.
So any other questions or suggestions from the forum? So if there is no questions, we can end the session. So again, it's a good initiative by Dr. Praveen and Department of Sports Physiotherapy. And we'll be having these sessions on other interesting patients or cases by the other departments as well. So we'll end the session with thank you. Thank you all.
Thank you, sir.